Good morning, everyone. Josh Winder, Penn State. It's great to be here with you. So we're going to primarily be talking about choledocholithiasis in bypass patients, but this certainly applies to any foregut altered patient. We're going to talk about a bunch of different techniques, but focus on transgastric ERCP and lap CBDE. So the first technique is balloon enteroscopy, so either single or double balloon enteroscopy. Basically using balloons to advance the tip of your scope using a caterpillar type motion to more distal or hard to reach parts of the GI tract. So this group in 2020 published their results of 60 patients who had altered foregut anatomy, half of which they were unable to reach either the ampulla or the HJ using typical endoscopic techniques. So by adding double balloon enteroscopy, they're able to increase their success rate from about 43% to 87%. Now that being said, they did have 2 perforations in that group, which I think illustrates that this is a technically difficult thing to do and isn't without harm. So an edge procedure is creating a controlled fistula between the gastric remnant and either the gastric pouch or a portion of the roux limb. This is done using EUS as well as a lumen-opposing metal stent, such as the one shown here. So in 2023, a multi-center trial demonstrated they had about a 95% success rate with this, but they did have some morbidities associated with it, including stent migration in up to 16%, and a persistent fistula in 31% of patients. Those aren't insurmountable comorbidities, but something to be aware of if you're considering sending your patient for an edge procedure. So if you have a patient that's clinically unstable and has bypass anatomy, PTC tube's not a bad option. So this is a patient that we had that came in a few months ago, bypass patient, floridly cholangitic, septic. I sent her to IR, they placed a PTC drain to decompress her biliary tree. We put her on antibiotics and resuscitated her. Then a few weeks later, we brought her back, and using a choledocoscope, we advanced the scope down through the tract. So this is a view of the common bile duct down near the ampulla. And using the choledocoscope, we could examine the entire tract. So here we are going through the ampulla out into the duodenum, and then coming back on the scope, we could see some mucus as well as a stone, this occluding stone. So I used an endoscopic basket. We were able to secure the stone. There you can see the stone clearly there. Unfortunately, this stone wasn't huge, and it was a single stone, so it was a fairly straightforward procedure. Once we grasped it within the basket, we pulled the stone out through the existing tract. The patient went home the same day, and we didn't have to put a tube back in. So transgastric ERCP is another great option. So it does require surgical gastrostomy in the remnant stomach to accommodate your side viewing duodenoscope. It can be done at the time of cholecystectomy, and when you perform your cholangiogram through your cystic ductotomy, you can place an antegrade wire that will facilitate your ERCP. It does require the morbidity of a gastrostomy tube if the patient requires repeat ERCP after the initial event. So if the patient has a CBD stent and they have to go back, the patient is going to go home with a gastrostomy tube, which none of them love. And it does require coordination between your endoscopist and your surgeon. So this is typically how we do it. You can see we have the remnant stomach elevated. In this case, we're placing T-anchors, but you can also do transfascial sutures and pexy the remnant stomach up against the abdominal wall. Once those T-fasteners are there, we make a gastrotomy, and then we introduce a 15-millimeter port through the abdominal wall and in through our gastrotomy into the remnant stomach. On that 15-millimeter port, we'll put an ultrasound probe cover and trying to keep everything sterile. And then through that, you can pass your side viewing duodenoscope. So here's a view, intragastric view with the duodenoscope. And then there's the ampulla there with the antegrade wire that we already placed. So all of the techniques I've shown you up to now do require advanced endoscopic techniques. And I personally think that lap transcystic common bile duct exploration really is a marriage of endoscopic and surgical techniques and really represents the best of both worlds. So it's surgeon performed. When you do your cholangiogram, you can see if stones are there or any defects at all. Pass a wire, pass your flexible choledocoscope. You can retrieve or fracture stones. And this is all done at the time of your cholecystectomy. So this is a case that I did a few months ago. A patient had acute cholecystitis. We did our cholangiogram. It looked like she had a stone proximally. So there I am going through our cystic ductotomy with a flexible scope. And in this case, I used an EHL probe or electrohydraulic lithotripsy to fracture the stone into smaller retrievable fragments. And then again, using that same basket, retrieve those stones until the duct was cleared. So we looked at our results from our previous experience with transgastric ERCP and compared them with transcystic approach. We actually presented this data earlier in this meeting, and we found that lap transcystic common metabolic exploration was superior with regards to operative time, postoperative length of stay, postoperative adverse events, and number of reoperations. We've essentially abandoned transgastric ERCP in favor of lap transcystic approaches in our practice. So to conclude, choledochal lithiasis in surgically altered patients, it's a difficult and tough problem. There are a lot of potential options out there, but I would encourage you to consider a lap transcystic approach if the patient has a gallbladder, if they have altered foregut anatomy, and if they could otherwise tolerate a laparoscopic surgery. Thank you very much.